All right, so I'll be starting with the new Odell edition now from this class onwards, whatever cases we'll do, as per the old roster also. So we'll be doing them from the new Odell. So what I just would see in this chapter also, I think there are only slightly newer additions to the original existing chapters and new chapters as well. So I think by this week's end also, I would be able to provide you with a list of new Odell cases that we'll be doing in the class. Of course, you would be doing all the cases. All the 75 cases has to be done by the September batch. I'm not emphasizing this for the March batch because they have spent all those months doing the old Odell. So I don't want you to feel stressed out and anxious about doing the newer Odell when you don't even have a clue that when the exam might happen. So you don't add on to that. But if at all the newer cases, some of the chapters are important, I would also let you know. So whatever new cases that we'll be doing with September batch, I would also recommend that at least those much you do the March candidates also. So do those cases as well for your exam if they are clinically relevant from the exam point of view. So Dinah, if you're here, can you just put this as a reminder for me for the end of this week? I have to provide a list of the new cases that needs to be discussed as class from Odell, the newer Odell. Yes, thank you. Apart from that, I'll be starting with case number 9 today as the first half of the lecture. And then after the break, we continue with our 1000 MCQ discussion from the end of file. Most likely we have to do it by page number 27. So we have 2-3 pages as a backlog as well. So let's see how far we can go today within the confines of the time of this lecture. So, and for everyone, because we have muted the classes and because we are having a flow of lecture. So I'm getting the personal doubts by each one of you, which I'm answering also. So I hope your doubts are also getting clarified. But please be assured that perio is going to be discussed a lot more, and in fact we still have to develop a lot of the base in the perio. So it was just a glimpse of what we'll be doing. So don't worry about still if not everything is making sense. Gradually everything will start making sense. Also, I would really like you to share the feedback with me on my personal chat now, because I had to actually stop putting the messages on the September group because of that confusion of the screenshots being shared. Now in few days I will open up the chat on the September group as well, because I think everybody's now getting the hang of quizzes and webinars because of a lot of screenshots and messages building up on that group. A lot of important information keeps getting lost. So to keep that intact and so that people are not finding and scrolling through the chats. So but please, I'll be opening up the chat on that group, but please make sure that it's only for very relevant information. Otherwise, whatever you can message me personally, please try to do that personally to me or discuss amongst your peers on the discussion group. That group solely would be for the sharing of references so that they're easy to find for everyone. So try to not start random chat or random messages on that main September group. That's all. That's the whole purpose of keeping that group. Yeah, all right. We'll just go through that. Yeah, but one thing I require from all of you is to send me the feedbacks, how the sessions are going for you, how the doubts are coming up for you, how the clarification is helping you. So I need to have your constant feedbacks because I cannot have that now live on this chat or on this live session. So please, after the class, definitely send me the feedbacks. However, you may want me to add or reduce or anything because I'm always open to your feedbacks, and that's what keeps us driving and striving for the better, and that keeps us achieving better results. Yeah, all right. I'll stick to keeping it close, please, because obviously keeping that close makes sure that only me and the chat posting relevant information and references, etc. Whatever the personal doubts you have, the web services you can talk to her, academics you can talk to me, and amongst yourselves you have your discussion group. So everything is actually well organized in that manner. But do send me your feedbacks on my personal chat. That's all. And yeah, without wasting much more time, let's start with today's class, and I will be starting with the Odell case first. It's one of the lengthy chapters, but then again, it's an extremely important concept from the exam point of view. What you will learn here would be theories and pulpitis. There would be introduction to pulpitis as well, the signs and symptoms, diagnosing, reading the signs and then understanding them, and then management of deeper restorations. We learn about affected, infected dentine. We learn about various restorative materials, their uses, indications, contraindications. So there is a lot to be learned from this chapter. This chapter is going to give you, say, about major 5 to 6 concepts, and all of those concepts are asked in the exam. Like 100%, this chapter concepts are going to be in the exam. So this chapter is definite short way of assuring a lot of questions in the exam. So that's how beneficial Odell is actually. That's why we do Odell continuously, because it gives you short concepts of the exam, which are definitely going to be there. So let's start with deep teres lesion and expect at least 50% of your part 1, paper 1 questions, 80 questions in paper 1, endo and cons, 50% of those would be revolving around these concepts. So that's how solid this chapter is going to be. So please make sure you're with me and not distracted. Keep taking notes, keep writing your doubts. You have to send me the doubts after the class. So please stay with me on this one. Yeah. All right. So let's start with the summary of this case. How will you deal with a deep cavitated caries lesion in a permanent maxillary molar tooth, which is this? This is a maxillary second molar, which is involved with deep caries lesion. Just a second here. All right, so this, you can see clinically it's a large caries lesion. It also is deeper, appears hollow, and there's also the white spots here involving the marginal ridge. This one also appears demineralized. So there's a lot of demineralized enamel here, which you can observe as your white spots. So white chalky spots, or now because here you see it along with a deep caries lesion, it's a cavitated lesion, the enamel has been fractured. If the surface was intact and this was only white chalky appearance, then it is called incipient caries or your white spot lesion. It's an incipient or an early caries lesion, most likely which is within the enamel and easily can get remineralized. But this tooth, however, is having a deep caries lesion, which is not an initial stage, it is an advanced stage. It has progressed deep down into the dentine, and then because dentine was also all infected and mushy, so the superficial lying enamel was no more able to stand the occlusion forces, and thus your enamel then undergoes fracture, and that's called cavitation. So once the cavitation has taken place, then the caries lesion becomes irreversible, and you cannot remineralize it, and then the restoration is definitely required. So Ivan's article, I have shared that also on the group, is an also important foundational article that you would be reading both for adolescent and adults. There are 2 variants of those articles. So along with this case, and then the first case that we did in Odell, which was high caries rate, and then Ivan's article, all these cases together, and plus those 2 Sturtevant chapters that I've asked you to read. So when you read these materials, I would request you, once you are through this, try to maybe just find a few hours together and revise all these together, or at least if not one day, but try to stick them together. Like today you're revising the Odell cases related to caries, then the next day you revise Ivan's, and the other day maybe Sturtevant. So when you read them, all this text together, first of all, it helps you in connecting all the dots and understanding the concept better, because you would be reading that in different ways. And the other is that it would solidify all your doubts, and it would solidify all your basic concepts building. So everything, because you'd be reading together, it would be totally sorted out once in one go. So try to do them simultaneously, or if not simultaneously over consecutive days. That would help you solidify this concept once for all. So that would be a great way to totally master your conservative part, because paper 1 cons part is all about caries and restorations, and Sturtevant, Odell cases and Ivan's is going to take care of all of that. So decks you're only doing once, but if these over that you do, then there's nothing that you cannot answer in your paper one. So that is how we take care of throughout all the 4 papers and all the subjects, mastering each topic as we go through it. Now we are at week 1 and week 2, we are concerned about your cons and endo. So let's solidify these concepts here itself in stone and then move forward. When you do that with each concept and each paper subject, then that's how you're solidifying each of the concepts. And trust me, each topic, each question is important. You cannot say I'm weak in theories, but that's okay, my endo will take care of that. No, nothing is going to compensate for the other. No subject, no concept is going to compensate for the other. So you have to make sure every concept. They're not asking the entire textbook. We know they're asking about few important topics. If we can master and solidify all of those, then leave no stone unturned for ABC concepts. That's what I'm intending to say here. So please follow that technique that you have to make sure you're mastering each of them on each of the concepts and subjects which get asked very, very refinedly, very, very solidified in a very solidified manner, which you can only achieve when you're reading it through all those important sources that I'm asking you to, so that no concept remains from your knowledge. So when you look at this, you must, all these things should start coming in your mind. Yes, I see a white spot. It's an initial incipient caries. This is a cavitated lesion here in the center. Why does it cavitate? Because enamel rods fracture. Why do they fracture? Because there's no dentine underneath to take all that occlusion load. So all that should start coming to you. This is how friendly, this is how equipped with knowledge you should be concerning with your caries and then management. So now history of this patient is, it's a 30-year-old patient who complains of severe attack of pain. Now you would also learn one thing. When they say severe attacks of pain, it not necessarily in the first go should click that it's irreversible pulpitis just because it's saying severe. Because certain terms are relative. One thing which may be severe to other may be milder in respect to the other, right? If it's a 9-second or maybe an 8-second attack of pain, it is severe than a 2-second attack of pain, but it is milder than a 1-minute attack of pain. So severe attack of pain is very relative. It may be severe today than it was 5 days back, but it may be milder, and maybe if you don't treat it a week later, it would be more severe. So severe is a very relative term. It doesn't initially give you the idea of irreversible pulpitis. So drop that habit that when you read these terms like severe, then it would always mean prolonged or continuous. It can mean it is a relative term, right? So drop those inhibitions that you read this word and you start thinking on irreversible times. No, we have to keep our mind open. It is just severe than what it was a few days back. So it is still a few seconds duration. Now that reinforces the fact that we were just discussing that it is only a few seconds. Earlier maybe it was just 1 or 2 seconds. Now it is maybe 6 or 7 seconds. So it's severe than that, but still not in the category of being put as irreversible. So let's not make our mind just with the term severe, because these terms would be given to you in the exam to mislead you, to confuse you. But what we are concerned with is complete history, complete nature of pain, which is only a few seconds duration and fades away slowly. She cannot identify, so it is also poorly localized. And we know that reversible pulpitis is poorly localized because in no ways PDL is involved. And early stages of irreversible also is poorly localized. So whatever it is amongst these two, it is either early stages or it's reversible. Then it is also sensitive to hot, cold, or sweet foods and cold air on the upper right jaw. It makes the pain worse. So it is coming with a stimulant. It is stimulated. It is not spontaneous. Nowhere it has been said that it comes on its own. So it's spontaneous. It lasts only a few seconds, fades away slowly on its own. You do not require analgesic. And then it's poorly localized, so it is more inclined towards your reversible pulpitis, as you can see. The pain has been present intermittently for several months and only recently become severe than it was a few months back. That means it was 1 to 2 seconds. Now it is few more seconds than that. But there's no pain on biting, which also correlates with the fact that it's poorly localized. If there was pain on biting, when PDL gets involved in the periapical area, it does become localized. So no pain on biting is absolutely correct and correlated with the history of poorly localized. Patient attends on a casual basis for dental treatment, despite the fact that this careless lesion is very large. Perhaps surprisingly also, it is the only lesion in an otherwise intact arch. There have been no other lesions in the last 3 years, and that's why the patient is at low risk. Patient is fit and well medically. Extraoral exam reveals no significant abnormality. There is no tenderness or swelling on the buccal or palatal roots. So as suspected in reversible pulpitis, there would be no tenderness or swelling. So tenderness or pain on palpation is found positive when there is an periapical abscess. So when the periapical area gets involved, there is pain on biting and also there is pain on palpation. So there is no pain on over your buccal and palatal roots upon palpation on the root surfaces. On the buccal and palatal gingiva, you would be palpating to assess that whether there is periodontal abscess or periapical abscess due to this pulpitis. Because periapical abscess would be the next after the irreversible pulpitis and necrosis has spread into the periapical region. So upon intraoral exam, on palpation, you don't find any pain or swelling there. That means the periapical status is still healthy. Now the maxillary right second molar is shown. What do you see and how do you assess the problem so far? There's a classic history of acute pulpitis. Acute, again, remember the fact that we have discussed this. Acute in endo means symptomatic, nothing else. Old standing newer infection doesn't matter. Acute pulpitis means it's symptomatic pulpitis. And that's true. Your reversible and irreversible pulpitis both are symptomatic. So they are acute pulpitis. And the repeated attacks of pain as opposed to a continuous severe pain probably indicates that pulp can be preserved if caries is treated. And the fact that there is no pain on biting, no tenderness over the roots on palpation, it also suggests that reversible pulpitis because there is no periapical periodontitis. So either it would have been early stages of irreversible, which does not involve periapical, or it could be reversible, which correlates with the duration of the pain sensation. So how to differentiate early irreversible and reversible is the duration of the pain. If it lasts less than 10 to 15 seconds, it's your reversible. If it comes only with stimulus, reversible. If it fades away on its own, reversible. Whereas if it's continuous, more than few seconds, more than 10 to 15 seconds, it's irreversible. If it is your throbbing and continuous pain, irreversible. If it is not going on its own and you have to take an analgesic, increases on lying down, irreversible. Right? So those are few signs and symptoms of irreversible pulpitis. Also, if it is spontaneous, comes without stimulus, again, the chances are irreversible. So that's how you look for these factors in the history and then easily identify whether it's reversible or irreversible. Not very difficult if you understand the nature of the pain. Then it's so easy to differentiate reversible and irreversible. And trust me, for exam, 90% of the questions you would need to know whether it's reversible or irreversible, because that's how your total management changes. And if you do not land up the correct diagnosis, trust me, with the domino effect, you're actually signing up for the next of the SBQs that would follow up with the wrong diagnosis. All the answers would automatically be wrong because you'll be answering as per the wrong diagnosis, wrong treatment, wrong management. So the domino effect takes place if with SBQs, especially because 5 questions are linked together. You identify wrong etiology, you identify wrong diagnosis, you're swiping off all the next upcoming questions because you would be answering based on the wrong diagnosis. So make sure your diagnosis part is extremely strong for your part 1 and also when you go for your clinicals part 2. Diagnosis, understanding of a disease and its management. These are your strongest points which get you through the exam, the entire ABC. Not just your part 1, but also for your part 2. So trust me, your understanding your oral medicine and disease and diagnosis should be extremely strong. You should just look at history and should be able to tell the diagnosis like that. If you get there, then you're very close to success. So There's a deep cavitated lesion, as you could see in the picture on the fusion surface. There was extensive exposed carious dentine. Opaque white demineralization of the marginal unsupported enamel indicates that it is demineralized, but it has not fractured yet. The slightly darker appearance of the tooth distally suggests that caries undermines enamel somewhat distally, and that is possibly involves the dentine supporting the enamel of mesial proximal surface. So both mesially as well as distally, you can see that it has been undermined. All that dentine below this unfractured enamel also lies affected. So it has been also undermined and is involved with caries. So this is relatively small upper second molar. Females tend to have smaller teeth, and when second molars are this small, usually the third molar may not have even developed. So this is going to influence that you might have to even save this tooth if the third molar is absent, because you need at least two molars there. Otherwise, it could have been extracted and third molar could be brought orthodontically in its place. So what investigation would you carry out? So first of all, because there is sinus symptom of pulpitis, you would require a tooth sensibility or a vitality test. And even though the symptoms suggest a vital pulp, there is still a large cavity in the molar, and partial pulp sensibility is a distinct possibility. So radiography is also required for a variety of reasons. The proximity of the lesion to the pulp, how close this caries is to the pulp, its lateral extent, and how much is the undermined structure, how much dentine is lost underneath all that enamel. Proximal enamel will all affect the overall restorability. Pulp size, whether it has been reduced or not by the development of reactionary or tertiary dentine, that will also be visible depending on the chronic nature of the caries process in this tooth. So this is the radiographic appearance. As you can see, this is the complete involvement of caries. This is a superficial enamel which is intact, but as you can see, the underlying dentine is involved, and that's why as clearly we could see that it is an unsupported enamel. All that dentine underneath is gone. So even here, if enamel is intact, but dentine is all involved, and this is all unsupported enamel. So easily the fracture or the occlusal forces can lead to the fracture. So this remaining enamel would be called unsupported, and that's also what is called what? Your weakened cusp. These are your weakened cusps because of undermining effect of dentine loss through caries. And now this is the pulp. So you can also see the original shadow of the pulp, a mild radiolucency. So that is the original extent of the pulp, and now this is the newer extent, and this all is your reactionary dentine or a tertiary dentine which has formed in response to your bacterial insult to the pulp, and which helps in protecting the pulp basically because it has been sealed off. The pulp has been sealed off and still there is some barrier. Now this all is the dentine barrier between the progressing caries and your face of pulp. So this is your reactionary dentine, and your pulp chamber appears reduced in your original height. Now it is also possible to see evidence of periapical periodontitis, widening of PDL, loss of your minor dura. All those periapical changes could have also been seen, but only if you were suspecting them. Then if you were suspecting all the periapical changes, you would have taken an IOPA, because you need a periapical view. But if you were not suspecting periapical, as in this case, because it was clearly reversible pulpitis, then and you suspected that maybe adjacent teeth had more caries, then in a single view, what you can take is your bite wing. So with bite wing, you can see multiple teeth. So if you suspect multiple caries and multiple teeth, then yes, bite wing is your view. But if you were suspecting a single tooth with periapical area involved, then you would have gone with your IOPA. If the symptoms were of irreversible type and there was a potential indication for RCT, then CT could have been also considered, although I would call it that too much of an overexposure. If there was not a complex canal anatomy, your IOPA would have sufficed. This imaging modality would give a much clearer indication of periapical pathology, anatomical changes, bone resorption, proximity of sinus floor, root canal apices that might be affected. So when you perform these investigations, first you took the cold vitality test. So tooth responded really quickly and strongly to ethyl chloride, indicating a hypersensitive pulp. That is a kind of exaggerated response to the cold test. That's called an exaggerated response to cold test. So that also gets asked as a question, by the way. In what condition would you get an exaggerated response to the pulp test? Now understand, even the irreversible pulpitis would give you an exaggerated response. You'll get more pain, or there would be a longer lasting response from the pain in the form of pain from the pulp in case of your irreversible also. But when they say exaggerated response to the pulp test, that's mostly used in terms of reversible pulpitis because it is going to be slightly stronger than your normal pulse response and more quickly. But it would also fade away briefly. But in irreversible pulpitis, it would be prolonged pain that would be elicited and not just an exaggerated response. Literally it would be exaggerated, but that's not the term used for irreversible. In irreversible, you would have a prolonged pain which would not go in on its own sometimes. You might have to give analgesic or inject a local anesthesia. So here it was quick and strong response indicating hypersensitive pulp, because obviously also the proximity of pulp to the cavity is also very close. So the response was elicited very quickly. Now the radiograph is shown. What do you see? So we just looked at the radiograph. The radiolucency indicates that the caries lesion is extensive, reaches the inner third of dentine close to the pulp. There appears to be a bridge of intact dentine between the lesion and the pulp chamber. Caries has undermined most of your occlusal enamel and also the distal enamel. There are no separate proximal lesions or cavitation. The coronal pulp chamber is rounded and reduced in size. Pulp horns obliterated by reactionary or tertiary dentine. I have highlighted and outlined all those features which you just read here, right? And also there is a finding here, if you look at it, that you see these radiolucencies more, but based on the location, these are more like your cervical burnout than your caries. If you have to confirm between the cervical burnout versus caries, the best way to differentiate both is that caries, if there is root here, structure here, and suppose you've got this radiolucency here. So on radiograph, if you find radiolucencies which is closer to or underneath the level of the bone, so your root caries in this area would only happen when the root is exposed. That means the bone level has to be down, and only then it would be most likely your root caries. But if it is inside your bone, that means the radiolucency is here and there's bone level which is above it, then it's most likely your cervical burnout. But with the bone resorbed, still you can find cervical burnout here. In that case, you have to clinically correlate. But if the bone is high and you have radiolucency, then even by looking at the radiograph, you can tell that this is by no means your root caries. Because for root caries, the root structure has to be exposed, the bone resorption has to be taken place. So there is slight radicular burnout of the dentine immediately above and below the mesial and distal DEJ. This could be mistaken for your caries extending from the crown into the distal root, but the shape and site does not suggest caries. And if other radiographs were taken, often the cervical burnout can be observed on other teeth in a similar anatomic location. Of course, findings on radiograph must be reconfirmed by clinical examination as well. So what is your diagnosis? The pulpal diagnosis is that it's acute reversible pulpitis in your maxillary second molar caused by extensive occlusal caries. Pulp still appears vital. There is no evidence of periapical inflammation or periapical periodontitis, and the pulp does not appear exposed radiographically. So the treatment plan. Now your diagnosis is done, your investigations were made that helped you come to the correct diagnosis. Now is the time to know what is your correct treatment and understand that there are various treatments possible for a single diagnosis. So it's not that if there is this diagnosis, the confirmed treatment is this. But then there are practically multiple treatment options available, what defines or what helps you in coming to the right treatment for the exam? First criteria is being minimally invasive and conservative as much as possible. The most conservative and still being and solving the problem for the patient would be the ideal situation. The other things could be your cost effectiveness or affordability by the patient, but before that, the first and the foremost is the most conservative, right? So if this tooth is restorable, that is being the most conservative choice here, yes, the prognosis is still guarded because the pulp can still lose its vitality anytime, either because of the caries, which it continues to progress, or when you place the restoration and the marginal gaps are there, there is going to be micro leakage, which will continue to allow the bacteria to percolate through the dentinal tubules and the pulp can easily get involved. So either through caries still existing, if you leave any caries behind, or you place restoration which is not sealing the margins, you can expect the secondary caries and you can involve the pulp very easily permanently. But there's no indication for immediate endodontic treatment yet. There is also sufficient supragingival tooth tissue available to support the restoration. Although many would call it an unsupported enamel and it is more prone to fracture, the prognosis of the coronal structure is also still guarded. But then this author promotes still going with direct, minimally invasive bonded restorations here, so that whatever remaining enamel is, you're protecting it, you're preserving it. You're not going with your full coverage restorations here. You're not going with endodontic treatment. So minimally invasive treatment would be the line of choice here. What will you do first? Now understand now what will you do first comes after the entire examination, investigations in the patient's mouth. It's not that patient came and sat and said, I have pain in this tooth, and you will start working on this tooth. That's not how this has been approached. So remember that in the exam also there will be a lot of questions and situations which will be like patient comes in pain, sits on your chair. What would be the first thing that you do? The first thing you do here is in treatment part, then you attend the pain. But once he sits on the chair, the treatment did not start the moment they sat on the chair. Now, even if they sat on the chair with pain as an emergency, if it's the first time you're looking at the patient, then it is required to conduct a complete mouth intraoral examination, extraoral examination, investigations, coming to the diagnosis, planning the treatment, and then executing it. And then the execution part of the treatment comes, then you come to the emergency component of the treatment. So I hope it's making sense to you. Emergency handling or the pain handling may be the first step in the treatment plan, but that's not the first thing that you do once the patient comes and sits on your chair with pain. You do a lot of other things which you did here, right? You took the vitality test, you took the radiograph, you took the history, you took the dental history, you took the medical history, you performed intraoral, extraoral exam. That's what you did. You came to a diagnosis and you planned treatment, and the first part of the treatment was handling the emergency component. So please understand, the instinctual answer can be the patient comes with pain, let's attend the pain first. No. Still, you do the complete exam, investigations. Patient can bear that for 5 more minutes if he's been bearing it for that long. So patient is in pain, immediate management response must be to relieve it. Pulpitis does not respond to analgesic drugs, and the appropriate treatment is suitable caries excavation and then restoration. Even if analgesic help here, the best method to always attend to a dental problem is to give an active dental treatment. Removal of the cause of pain or infection. In this situation, the removal of irritant or infection would be the removal of caries. So excavate all that caries that is stimulating and irritating the pulp and then restore it. If a definite restoration cannot be placed immediately, a provisional dressing could be placed following the selective excavation of careless tissues. Now this would help relieve the pain by removing the stimulus because you remove the bacterial products, the bacterial acids which are penetrating and irritating the pulp. And then you insulate it by giving some form of temporary restoration. You can give eugenol containing temporary filling, but you should not be giving it if your final restoration is going to be composite, because the eugenol component of ZOE restoration affects the polymerization process and interferes with the bonding and thus gives you weaker bonds or not so completely formed bonds, and which leads to failure, micro leakage. So if your final restoration is going to be composite, ZOE should not be used, or if you're using a zinc oxide based temporary restoration, it should be eugenol free. Zinc oxide has nothing against composites, it's eugenol that's problematic. So use eugenol free zinc oxide based restoration. Then the second alternative is use a longer term provisional restoration with indirect therapeutic pulp protection as required in an attempt to induce further reactionary dentine formation in the pulp, which could be maybe by base you give calcium hydroxide base, and then over that you give a moderate long span your GICs. However, the caries lesion does not appear to be an imminent danger of breaching the pulp. Indeed, a growing body of evidence argues that an indirect pulp protection is not necessary or beneficial because of the modern composite restorations and their bonding agents have the desired properties of pulp protection materials. Then removal of caries will leave a weakened crown. Once you remove all that caries dentine, you have a weakened crown. The tooth structure is gone, the enamel is remaining there, undermined, weakened, unsupported. More susceptible to fracture under normal occlusion load. This clinical picture is entirely clear to all. An immediate definite restoration is that's why the best course of action. Not just in this situation. Now this question also gets asked a lot in the exam. When you come to the SPQ, you'll be solving a lot more of them. There's caries, deep caries, you decide. So there would be 2 options. Give a sedative dressing. There is reversible pulpitis. I'm giving you 2 options. In the exam also you get 2 options. Give a sedative dressing, and the second option would be give a composite restoration with intact margins and do the permanent restoration. As per today's standards, do your final composite restoration. In the first 4, you do not require to answer the sedative dressing as your answer. So please also emphasize that wherever you're keeping your notes. If you have the choice of temporary sedative restoration versus permanent restoration with intact margins, please go ahead with your immediate permanent restoration if your caries are not directly or almost touching pulp, like in this case. It might be close to pulp if it's not touching pulp, but there's no risk of that it might, get irreversible anytime. As this case also you see a sufficient amount of bridge. In those situations, please go ahead with permanent restoration. You're not in a worry of putting a sedative dressing. Only if it was almost touching. On radiograph, it's almost touching, or with whatever little dentine is remaining there, if you remove that, it's an exposed pulp. Then that's your IPC. Then you need to give a calcium hydroxide barrier. And then you might require even a temporary restoration because your pulpal diagnosis is a fix. In this case, there is sufficient dentine, you do not require IPC. The affected dentine which you remove gradually is not going to expose the pulp. So that's why a permanent restoration would be given immediately. Subsequently, the patient also needs a full caries risk assessment, intensive preventive regime, which will include topical fluorides if other lesions are found or dug up. So more on your fluorides, please read through your TG. The new TG has given beautiful tables for the use of fluorides, the mouthwashes, the toothpastes, the varnishes, the gels, the fluoride with CPP-ACT. Now CPP-ACT was always in grays. We never knew before this what to answer. But the new TG thankfully has given us direct answers for CPP-ACT. So March guys, if you're confused with that, you can actually go to the chapter, I think it's in caries, there's fluoride, and then read under CPP-ACT in caries chapter. They've given you some direct answers there. So it's given directly in that new TG that you should never be replacing fluoride with CPP-ACT. It is showing promise in remineralizing. So it is definitely there to remineralize, but it should never take place of fluoride. It can only be an adjunct to fluoride. So that's your direct answer there. Whenever in an exam, you're being given options. Fluoride on this tooth, CPP on this tooth, separate options. And you've been confused what to answer. Fluoride should be your always first choice. CPP-ACT always as an adjunct with fluoride. Direct answers pretty straightforward. They're written in the new TG. I keep mentioning as and when I go through the TG what are the differences, so the March guys can also go back and refresh. And also for the September guys, we are getting newer answers from some dark gray backgrounds previously. Because previously we had those gray areas. We never knew directly that what to do with CPP, ACP. Because TG always put them at there's always not enough data or it's a newer material to be commented upon. So it's good that they've given us a definite take on that. So for September also, we are revising the newer takes. For March also, keep that in mind. So even if it's not in the older one, but we have a standout decision for such things. Yeah. And also the new, I'm looking up new questions from new TGs. So most likely I will be making somewhere about 300 to 400 questions on the new TG. After your first 10 weeks of all the mock tests, all the different subject mock tests, we'll start with the TG mock tests. Yeah, so that would happen in about 10 weeks from now. So keep reading your new TGs, and after the 10 weeks, you will be given the quizzes based on the new TGs. So then you can start revising them. So that will help you very much in solidifying your TG concepts. Yeah, so that is going to be great learning experience. You'll have fun doing that. So I'm excited for that. I hope you guys are too. So let's look forward to that. Okay, so that's the whole thing about your caries, this particular tooth, how badly it's affected, and what are we going to do about it. So why not extract this tooth? Because it's a large lesion in a casual dental patient and might well lead to extraction if that's what the patient's wish. However, it's a young patient. She may not have a third molar. If present, it may not erupt spontaneously after extraction of the second molar. Prognosis here may be guarded. There's a good chance that this tooth would still be retained for many years, and with careful maintenance by the patient, aided by recall consultations, when you're carefully assessing the margins, you're maintaining oral hygiene, you're putting the patient on recall, you're observing it for the fractures, for the gaps, for the marginal discrepancies, this would be a better immediate option because the condition of the rest of the dentition has also not yet been fully assessed. So that's what you learned here, that if you can conserve, please conserve. So minimally invasive operative treatment, that's an accepted operative treatment. You can apply that in your exam as well now. How will you provide analgesia? Buccal infiltration of a local anesthetic, including a vasoconstrictor, should be sufficient. There is no continuous pulpal pain to suggest that obtaining analgesia in this area would be a problem. Because usually where there's irreversible pulpitis, the threshold and the morphology of the roots have changed, the morphology of the nerves have changed, sorry. So when the morphology of the nerves have changed, then they respond to your vasoconstrictor, respond to the local anesthesia in a different way, so that the threshold actually has been lowered to pain, so it usually doesn't get anesthetized very easily. But that morphological changes usually apply to the concept of mandibular nerve, not much in maxillary. In the maxillary area, where the LAs are not affected, the concept that works is lower pH. I will be taking that question and concept in the 1000 MCQs. I will be also showing you references from Walton. What Walton has to say about ineffective LA in areas of irreversible pulpitis in mandibular teeth versus your maxillary teeth. So just I'm giving you the gist here. For maxillary teeth, the concept that applies is your lower pH. Lower pH makes the LA ineffective, so less ions are available and thus less effect of LA. Whereas because in mandibular teeth, you're not injecting at the site of infection, so the pH concept cannot be applied. You're injecting at the area of the nerve block where it's entering. There's no infection. The infection is in the site of the molar root. Then how does the pH concept apply there? There the pH concept doesn't apply. And what it says, most likely what explains the failure of mandibular nerve block in the cases of irreversible pulpitis molars is that because of inflammation, the nerve endings, morphological changes take place which spread throughout the nerve, and that lowers the threshold of the nerve, pain threshold of the nerve. So it gets triggered by even small amount of stimulus because the threshold has been reduced. So LA is not much affected. In those situations, what do you do? And also it's mentioned here, if your LA fails, and that is also very commonly asked question in the exam, what happens when your LA fails, when your block fails, right? So if your infiltration or your block fails, then you give a supplemental anesthesia. Supplemental is you do a palatal infiltration or you give an intraligamentary injection. If you think your block was sufficiently given and you did not miss the anatomical landmark, then you do not need to give the block again. No, don't overdose that. It is because of the neural changes or the surrounding pH changes. So you give supplemental anesthesia, as in do a different technique and add on to that anesthesia by giving intraligamentary or palatal infiltration in this case, because you first give buccal infiltration. So you're not repeating the buccal infiltration. You're actually giving a supplemental palatal infiltration or intraligamentary. That is your appropriate next step. Dinah, if you can actually remind me, I would like to share the reference for the same. The supplemental anesthesia technique. Once your anesthesia fails, yeah, that's an important one. You must know because this happens all the time. Actually, we tend to overlook such minor concepts, but in the exam they actually pick up such minor concepts and they ask you what to do. So you might instinctively say, okay, my block has failed. Maybe I'll just re-inject the block. No, if you're sure that your technique was right, you do not inject the block again. You do not give any dose of LA extra, which is not required. No. So is a rubber dam essential? Well, yes, it is, because there's a risk of pulp exposure. Even if there was a small pulp exposure, contamination by the oral fluids can reduce the chances of your subsequent endodontic treatment that you would be required to do that. The lesion is extensive. Some carious tissue will have to be retained. The marginal seal of the restoration will be critical to its final success. The micro leakage can actually put all your efforts in vain if there was not an intact marginal seal. An adhesive restoration will require a controllable dry field to achieve the best seal. A rubber dam will help you with soft tissues, give you better visibility and access. Final quality of restorations placed under rubber dam are considered to get a higher quality than those placed without rubber dam. Then how would you gain access to this lesion? How much enamel needs to be removed? So the lesion is already open, cavitated, making access to the dentine. Taking access to the dentine is straightforward here, but much of the peripheral occlusal enamel is demineralized, unsupported, weakened. We know that, we have seen that. Ideally, your enamel at margins should be completely sound to ensure that etching and adhesion are most effective. Unfortunately, this is not always easy to assess clinically. All your frosted, demineralized, unsupported friable enamel must be ideally removed. Pressure with a hand instrument will fracture off unsupported enamel if the operator is unsure. Compromises might have to be made to conserve the cusp enamel. Once the enamel joining the cusp and marginal ridges, that forms a thick outer parameter of the occlusal surface. If it is lost, then much of the intrinsic structural strength of the crown is lost. A simple tungsten carbide or a diamond burr in an air turbine handpiece or hand instruments can be used to remove the enamel and introduce a slight bevel if required. How should you remove the caries dentine? Conventionally, it should be removed with large, slow-speed, rose-head carbon steel burrs and hand excavators. Possible alternative techniques are given in the table, which are not much relevant. No method is completely guaranteed to remove only necessary amount of caries dentine. Best methods are whatever which works best for the clinician, which gives the clinician the most tactile feedback. So it depends on the clinician's preference also. So none of these methods would be ideal for all the clinicians. How much caries dentine needs to be removed? Now that is an important question. The correct amount to be removed is the minimum required to restore the tooth successfully, allow your dentine pulp complex to stimulate healing, prevent the further disease progression. So you should remove enough that there is no bacteria or bacterial acids there, but sufficient dentine and pulp remains so that the newer dentinal bridge can be laid down to prevent the further progression. To achieve this, it is necessary to understand the different structure of different parts of caries lesion. There is a continuous histological spectrum of degree of dentine destruction in caries, and we learn those layers of stages or layers of classification of caries. So let's look at what are the layers of carious dentin, histological layers. One is the superficial, which is closest to the enamel at the topmost layer. Then is your middle one, and then is deepest, which is closest to the pulp. The topmost is called your contaminated zone. The middle one is bacterial penetration, or again, it would be also contaminated. The deepest is the demineralization, where the bacteria has not yet penetrated, but the acid from the bacterial byproducts has actually reached and has started to demineralize, only take away the calcific or inorganic part of the dentin. The collagen is still intact. In your contaminated and destructive zones, the collagen is destructed, is demineralized, and is also contaminated with bacteria, and that's why that's called your infected zone. They're all irreversibly denatured and demineralized. You cannot remineralize it, you cannot reverse it. It is necrotic dentin with very little residual tubular structure and lateral clefts. But odontoblastic processes are also lost in this area. Then in your middle zone, bacteria penetrates along the tubules, widened by demineralization, but there would be less damage to the tubular structure. That means the collagen may be still intact somewhere or the other. Odontoblast would be lost. Then there is comparatively from your top layer a little less loss of mineral and a little less loss of collagen breakdown. So dentin and enamel, they both have two components, organic and inorganic. Organic contains your collagen part, which is composed of your glycoproteins. Inorganic is composed of your calcium and your other minerals, basically. So carbonates, calciums are all your inorganic component. That is your calcified. The hardness is imparted to your dentin and enamel through the inorganic part. The basic structure is given by your organic component. So loss of mineral means loss of inorganic component. Collagen breakdown means loss of organic component. So always remember these two broad categories, and so the imagination part becomes easier. When you remember the two helps you understand the fluoride mechanism, it helps you understand the caries mechanism, it helps you understand the EDTA, the decalcification, the root canal preparation. Everything starts to make more sense when you understand the basic structure of the tissues that you're dealing with. So please understand them. Now the deepest or the affected is where the tubules are widened by the acid which got percolated ahead of the bacteria. The bacteria is not here yet, the acid is here. Dentin is softened but structurally intact. The odontoblastic processes are lost. Some bacteria may be present in the zone but significantly less as compared to infected zones which are more superficial. And this is a remineralizable or maybe a reversible caries zone. So now here the tubules are widened by demineralization. It can more easily be penetrated by bacteria. Between this layer and the surface is progressive destruction of dentin by both demineralization and proteolysis. So demineralization means loss of inorganic component. Proteolysis means loss of organic component. Simply, I mean, these words start making sense once you understand what tissues they are attacking. So demineralization attacks your inorganic part. Proteolysis attacks the protein part, which is the organic part. That's your collagen. So it becomes more understandable. So dentin structure is then totally destroyed because the mineral is gone, the protein is gone, nothing remains, and there's numerous bacteria living within it. Now this continuous spectrum of destruction is divided conventionally into zones, which you just read, that it's your penetration zone, then the lowest layer is your affected zone. So topmost are your destruction and penetration, and the most inferior, the deepest layer is your affected. So in addition, there are changes in dentin caused by reactions of pulp dentin. Now this is the caries, how it comes in layers. What is the response from the pulp? The pulp response would be from underneath. Caries is coming from top, the pulp is showing you response from the underneath. Let's look at that as well. Let's see what pulp has got to do. So pulp gives you three responses: peritubular reactionary dentin, regular reactionary dentin, irregular reactionary dentin. So peritubular reactionary dentin falls on the inner wall of tubules where your odontoblast processes are alive. Gradually what it does, it completely blocks the tubules around the sides of caries lesion to block it off between the caries and pulp. It completely occludes and obliterates the tubules and completely makes the dentin translucent because now dentin is completely filled with mineral component. And because more mineral is there, if you look at it on radiograph, it would be more radio dense, that would be more radio opaque. So this would be known as translucent zone. Do not confuse it with the translucent zone as enamel caries, which is quite different. Now the circumpulpal dentin, we have discussed that when we did the dentin anatomy. From the DEJ to the enamel, if you remember that funnel diagram that I drew, very dramatic but easy to remember. So the diameter is wider towards your pulp and is narrow towards your enamel. So the circumpulpal dentin has a larger tubule diameter, absolutely correct, and it is softer, more porous than dentin farther from the pulp. Here it's more calcified, here there's less calcification. So peri or intratubular sclerosis is actually very helpful in the deepest layers because here the diameter is wider. So where the wide diameter is there, the chances of bacterial contamination are also higher. So when you sclerose them, when you fill them with all that mineral component as a reactionary dentin, you're actually sealing off that part from the caries progression. So look, you can see that here as a red line here. This C layer here is your peritubular reactionary dentin. That is sclerosis dentin. Underneath that is your D layer, which is your regular or irregular reactionary dentin. So regular and irregular reactionary dentin means below the sclerotic dentin, then pulp still obliterates the pulp horns, pulp still develops more dentin. More amount of dentin is laid down in response to a stimulus. That's why it is a tertiary dentin, because it is in response to a stimulus, a chemical irritant or a biological irritant. If it is formed slowly, then it's called regular dentin. If it's formed haphazardly, rapidly, it's called irregular reactionary dentin. Because the regular one is formed slowly, so it is much more uniformly organized, uniformly mineralized, and thus gives a good barrier to caries. Whereas irregular one, because it's laid haphazardly and rapidly, may not be as well calcified, so it's not as good a barrier as your regular reactionary dentin. But both serves the purpose of blocking off dentin, and thus you see it here in the diagram. Underneath your peritubular reactionary dentin, which is your sclerosed dentin, is your is your D dentin, which has cut off the pulp, reduced the pulp size, pulp chamber size. That's your reactionary dentin there. And E here shows the pulp horns, which can show you signs of pulpitis, like your reversible pulpitis in this case. These are the zones here. Your superficial layer is the penetration, the zone of contamination, and then below the red line is your affected dentin, right? The zone of demineralization. So basically all these layers understood, I assume. Very well informed table is given, and I hope it all made sense. So this is how you have zones and layers. Now how can you recognize this excavation point where you know that you only have to remove till your middle layer, that's your penetration, bacterial penetration layer, and save the demineralized or affected dentin? How would you tell clinically? Because these are all histological layers, it is very difficult to identify them clinically. The relatively smooth lines which mark the edges of the zones, they do not reflect the irregularly shaped advancing fronts and the small towns of bacteria which can penetrate tubules in advance of the main lesion. Again, it should be emphasized that these zones are only histologically distinct, but they blend when you are talking about clinical boundaries. It is accepted universally that not all bacteria have to be removed during excavation, which gets sealed off from the whole environment and the substrate is cut off, will either die or become dormant. Only few. Some can actually live off in the substrates within the dental tubule, so only few can get sealed off and can maybe eventually die or become dormant. Provided the restoration provides a good seal, the retained bacteria will not be sufficient to allow the caries to progress or process below this restoration. Then excavation of grossly contaminated or infected dentine is relatively easier and straightforward because it's superficial, very soft, mushy, wet, and darkly stained, and which is highly contaminated and would be readily removed. Whether the underlying demineralized caries affected dentine, which can potentially be repaired by dentine pulp complex, may be spared is a decision that must be made on case by case. So whatever affected dentine, it should be left or it should be removed, depends on case by case. It's usually preserved in the cavity which are deep to protect the pulp, but cleared from around your DEJ so that there is no remaining caries on your DEJ, because DEJ gives you a lateral spread. So any remaining caries on the DEJ will give you much more corneal destruction eventually, because DEJ gives you a lateral spread between the dentine and enamel. So if at all affected dentine should be removed from the base over the pulp, but should be removed from your DEJ. Then demineralized dentine is often stained. It's softer than your surrounding healthy dentine. And possible clinical indicator that the boundary zone between infected and affected has been reached is that the surface would feel more scratchy and sticky with the sharp dental probe, and sometimes leathery but would not be wet. Unfortunately, this cannot be appreciated from the textbook words, but only has to be experienced and should be only felt by sensation. Should you use your caries detector dyes? Well, then answer for them is no, because they over-exaggerate the extent of infected dentine, because they actually stain all the denatured collagen, all your demineralized collagen. So they also stain affected dentine, and they also sometimes stain sound dentine. So removing all your dye-stained dentine can lead to unnecessary excessive dentine removal. New caries indicators that are still being developed to detect bacterial metabolism and have the potential to identify only your infected or bacteria-containing zones, but they are not readily available yet. So the occurrence after initial caries removal is shown. What do you see? So the picture is when you have only removed the infected dentine. Here in this picture, you still see the flakes, you still see the flakiness of dentine. So the dentine surface is still friable and flakes which are parallel to the surface along the clefts that are a result of bacterial breaking out of the tubules. Base of the cavity must still be in contaminated infected zone at this stage, and it has just started to feel scratchy with the probe. Further caries needs to be removed. After final removal, the next picture is 9.6, where you can appreciate all the harder, lighter looking dentine, and also much more, less flakiness and more hardness. So more dentine has been removed, affected dentine over the pulp has been retained. It doesn't show the gross flaking, but it's still stained. It's but dry and a pure matter. It is still noticeably soft, but distinctly scratchy with a sharp probe. Consideration must be given to the relative hardness of the dentine retained at the base of the final cavity. If it's too soft, there's risk of also failure of bonding. And then this decision must also take into account relative pulp proximity. Unnecessary exposure of a still vital pulp can also significantly reduce the success rate of maintaining the pulp sensibility and should be avoided. So it's more of a clinical judgment. Should this restoration have a measle box? Just a second. Yeah. So should this restoration be given a measle box with preparation? The DEJ is visible in 9.6 if you can see here. Let me just show you here. So this demarcation, this line, absolutely. If you see my cursor moving on this line, yeah, so the right to it is your enamel, the left to it is your dentine, and that's your DEJ. So DEJ is clearly visible from the top. That means all this overlying enamel has no dentine underneath. It's all unsupported. So should you give a measle box? Well, that's all unsupported enamel there, and it will fracture, leading to the failure of restoration. If you were giving amalgam, then you would be requiring measle and distal boxes, because with the condensation forces of amalgam only, your fracture will happen. But if you're removing measle and distal enamel, it can seriously compromise the strength of remaining crown structure. So even if it's with your guarded prognosis, retaining and preserving all this enamel, unsupported enamel, will provide some support to your corneal remaining structure. So it must be accepted that leaving this enamel comes with the risk of failure, but there is much more benefit of a much more conservative approach, which outweighs the risk of fractures. So proximal caries, adverse occlusion, or possibility that patient might not come back to you for regular recall can also affect your decision. If the patient is readily available, maintaining oral hygiene, coming for regular checkups, then you may take that risk. So you have left caries under this restoration, and it will fail. If that's a question. So in the past, if this cavity preparation would have considered inadequate, the soft and stained dentine remaining on the cavity floor would be considered as caries left behind. But then there are certainly some bacteria also remaining in that dentine. If this cavity were to be restored with a modern high copper alloy amalgam with its inherently poor marginal seal, the restoration might fail fairly quickly. But if you're using your composite restoration, adhesive restorations, the chances of achieving intact marginal seal is higher, and also the caries dentine can remineralize biologically, and the caries can arrest if you achieve intact marginal seal. So there's a risk that this more conservative approach will lead to failure if your restoration is not up to the mark, if the marginal seal is not up to the mark. So leaving more carious tissue than was accepted in the past does carry a risk, but the affected dentine has been left behind for specific justifiable reasons here to get it all remineralized, achieving intact seal with your composites. This MI approach, minimally invasive approach, will require continuous monitoring and good patient behavioral adherence to oral hygiene regimes. Annual review will permit any visual changes to the restoration, and then you can keep checking for the gaps or roughness with your blunt explorer so that you're not fracturing it yourself. And the ultimate success of this operative management is dependent on case selection, appropriate selective caries removal protocol, appropriate handling, placement techniques, biointeractive restorative material, and the patient's ability to maintain your long-term plaque control. Now, what is stepwise excavation? The other method could have been that you did not remove all your, or did not give a permanent restoration in one go. Rather, it's a technique where the caries is removed in increments so that your dentine pulp complex is allowed to heal. Superficial infected dentine is removed first, then you give a temporary restoration rather than a permanent restoration. After a period of months, you remove that temporary restoration and you check the floor again, and you find a darker arrested carious dentine, which is darker, harder, and drier. But now, with the accuracy and predictability of your restorative material, you do not require this technique of re-venturing into the tooth structure, because that leads to the loss of more tooth structure. You may not require to go back after 6 to 9 months and check for that hard dentine floor. It suggests that now it is an unnecessary step. You have modern adhesive restorations available, which will give you with predictability that this hardness will develop without you have to explore it again. So now this technique of two-step excavation has become redundant. Now the notes might record that this tooth has been excavated conservatively, and repeated restoration can be delayed until either the restoration peripherally fails or some unsupported enamel has fractured off. At that stage, a decision can be made about further excavation. After removal of a failed restoration, if you find that cavity floor is hard and dry, you do not require to remove anything else. Just give a new restoration. Do you require lining for the pulp protection in this case? Now liners or bases would be required to protect the pulp from the bacterial insult, acids, and toxins, to seal it and to prevent the impregnation or mechanical reinforcement of any layer of caries affected dentine, to stimulate the pulp complex to lay down further more reactionary dentine, especially when you're using a calcium hydroxide base. Because of its higher pH, it stimulates new odontoblast formation. That's called neo-odontoblasts. New odontoblast get formed, new reactionary dentine gets laid down. And it also protects from thermal, electrical, and mechanical stimuli. Now, current restorative materials do not require separate lining. In nowadays, and the use is also debatable. Now, what materials could you use to restore the cavity? So you can use any of these, like your resin composites, GICs, adhesive sandwich technique, using GIC as a base, and on top you give your composites, then or use your amalgam. Now, amalgam should not be used or should be considered phase down, which is a minimum treaty in 2017, which actually was taken down to phase down amalgam, which suggested that now the amalgam, considering it gives you much more mercury biohazard or mercury waste in the environment, so should be phased down and should be avoided wherever possible. So there is advantages and disadvantages of all these materials. Like resins come with good aesthetics, good wear characteristics, mechanical properties, but they're very technique sensitive. They come with shrinkage drawback. GIC comes with, well, it's less technique sensitive. You can use it for bulk filling, but then for long term, they don't have the longevity. They don't have aesthetics. They don't have mechanical properties. Now you can use the best of both by giving GIC as the base, which replaces the dentine, and on top you get aesthetics of composite, but that comes with technique sensitivity again. So you have to pick between all, and none is more superior than the other. It is also clinician's choice. For sure, your composites and amalgams or your sandwich technique would be superior from your GIC alone, mechanically speaking. So what was the most appropriate choice here? Well, there's no absolute correct answer. Here they decided to use a resin composite. It would adhere well to your extensive supragingival margins, supporting your surrounding tooth structure because of its adhesion and bonding, and it would also support that unsupported enamel. One disadvantage is that it will give you your polymerization shrinkage stress. So if you put it in bulk, it might create so much polymerization stress that it actually fractures your enamel. So to prevent that, use it in minimal increments so that your polymerization shrinkage stress is also minimalized. This is especially important in this case, where there is considerably poorly supported enamel. You can actually overcome that by also using modern materials available, which come under the claims of less shrinkage by volume. So the final restoration is done, it was finished, polished, giving you a final lustrous restorative surface, which has given you superior aesthetics here. Are there any medical legal considerations when you're practicing your MI operative approach because you have left behind the enamel, which is prone to fracture? Can you get into medical legal trouble with that? Well, if you are maintaining the notes, if you're involving your patient in the decision-making journey with all the options and material risks discussed, photographs were taken with each step, the records and the reports were maintained, consents were taken, then medical legally there is sufficient clinical and scientific evidence that your minimally invasive approach is a valid alternative to conventional complete excavation protocols. Now, there's one onus to this is that the oral healthcare practitioner to offer this option as an alternative to the traditional approach. It's your job to offer this. Ignorance and lack of clinical knowledge or skill is not a defense in a court of law. You might also get sued for the fact that you actually did not use it as your approach. And you cannot brush it off by saying, I did not know this, I did not have the skill. That would not be your defense. So you might actually be sued off for not using or offering this as an option to this patient to your traditional approach. The patient might be so informed and tells you, you actually took off more of my dentine was required. So please offer this and maintain the records that this option was also discussed with the patient, and then as decided and with consent, you either went with it or you did not went with it. Whatever happened was with your patient's discussion, you offering this at least as one approach. I hope that's making sense, medically legally. Yes, sir, please, some. Yeah, okay, perfect. So the MI approach is being taught and can be referenced in many textbooks. So it is actually an onus. You must also tell your patients about it and should also prefer wherever the patients or the situation demands so. So that's the end of the case discussion. And I really hope that it brought into the spotlight a lot of concepts, a lot of factors, a lot of topics that actually have seen repeatedly getting asked in the exam. So go back, definitely discuss it amongst each other, revise this concept, revise this entire chapter, revise it with the ones, revise it with the first chapter of Odell, do some Sturtevant reading as well. Gradually and eventually when you build on, it will all start making sense together beautifully. You will be surprised how well confidently you can handle such cases, and these are your bread and butter. Your restorations, your RCTs are your bread and butter in dentistry when you also start getting into practice. So not just for your exam, but also as a clinician, you'll be far more confident when you approach your patient with such techniques. So all these classes, all this learning that we're doing here, this just doesn't stop with you and me after the exam. This goes on a long way with you. So a part of me also goes on a long way with you. So I hope you continue to apply these information, you continue to apply these skills in long run. Affected dentine, surrounding that affected dilated wide dentine, the peritubular dentine, in that peritubular dentine, your sclerosis happens. Now peritubular dentine is surrounding your dentine. If you look at the diagram here, peritubular dentine is your dentine which is surrounding your tubules. So that also gets laid down with your excessive mineral component. Also interdentine, within the dentine, you get your excessive mineral. Within the dentinal tubules also, you get all that mineral sclerosis developing. So that's what your peritubular reparative dentine or reactionary dentine formation is. That's your sclerosed dentine. Spontaneous pain. What was the logic for pulpitis? Spontaneous, without any stimulus, is specifically pathognomonic sign of irreversible pulpitis. Reversible doesn't happen on its own. Spontaneously, no. It comes with stimulus. Irreversible happens with spontaneous. Irreversible can happen with stimulus, without stimulus also. When it happens without stimulus, it is called spontaneous pain. Isn't the affected dentine hard? Yes, it is harder than your infected dentine, but it is less hard compared to your sound dentine. Relative term. Ethyl alcohol and dry ice are absolutely not same. One is alcohol and one is dry carbon dioxide. Ethyl alcohol is alcohol, dry ice is your carbon dioxide snow. Absolutely chemically different. All right, so more doubts, please. MI is minimally invasive. It's mentioned here, Nadia. When you started this technique, MI, they mentioned it's minimally invasive approach. All right, so more doubts on my WhatsApp, please. Now is the time we take a break, and we have a lot more to do today. We have to start with the 1000 MCQ discussion. We have the backlog. No, they did not do the measle box, Patricia. They said if they were going with for amalgam, then they would have done the measle box or the distal box. With amalgam, with your composite, they have all gone into risk taking and preserved all the unsupported enamel. Okay? They did not do it. All right, so let's take a 15 minutes, not 20, but a 15 minute, and I'll see you guys in 15 from now, and we'll start with your MCQ discussion. So Dinah, please remind me after the class, I have to share the solve with notes, new Odell file as well. So I'll see you guys in 15 minutes from now. Start with page number 18 after the break. All right, I'll see you. Yes, so let's start with our 1000 MCQ discussion today. And we'll be taking off from where we left off, page number 18. So now what are the dangers of using air as a cooler during your cavity cutting? So I've also explained this in last classes, if you remember, that do not use your air blast or your air syringe to cool off or dry off your cavity preparations. Because when you put the air blast with pressure on your dentinal tubules, then it leads to the withdrawal or the drawing in of your odontoblast tubules, and it can be permanent in some situations, making them as empty tracks. So hypersensitivity can be one danger. You might feel sensitivity, but that is only a short-term sensation. On a longer run, the longer or the major danger that's coming out of using air with the blast or pressure is that it leads to the withdrawal of odontoblasts, and thus also their retraction within the pulp permanently, where the odontoblast process may never come back into the dentinal tubules. So that makes them the dentinal tubules as empty tracks. So that's the major danger here. In RCT, ideal root filling, also we discussed this concept. Ideal root filling has to be where your dentino-cemental junction is, or which is your narrowest part of the pulp. Dentino-cemental junction. So 1.5 to 1.5 mm short of your anatomical apex or radiographic apex. That's where your root filling should be achieved. So it's a natural constriction, the narrowest part, and that's where your RCT should end. So it should be at your dentino-cemental junction, not at your radiographic apex and not beyond your apex. This is exactly at this point where it needs to terminate. Again, what is the narrowest part of the pulp? Another variant of the same question, same concept, is the dentino-cemental junction, which is the narrowest part of the pulp. That's where you're supposed to achieve your working length. Till there, you should prepare your canals, and that's where you should get your tuck back of the master cone of GP. Which of the following is most useful in differentiating between apical abscess and periodontal abscess? Like we discussed in the last class, also the concept is that apical abscess originates from a non-vital pulp and periodontal abscess originates from a periodontal pocket, which gets obscured by calculus. So in initial stages, when the concomitant infections does not happen, that means the secondary peri or the secondary endo doesn't happen from each of them. Till that time, the vitality is intact in your periodontal abscess, whereas it is lost in your apical abscess. So vitality test needs to be done. And if you're given the choice of both cold and heat test, then we know that cold test is the most superior in determining the vitality, and thus your answer. What is the ideal length for a post in a post-core treated tooth, in an endodontically treated tooth? So whenever you're giving post in a canal, the ideal reference should be the root length. It should be 2/3 of the root length. And if that cannot be taken as your reference, then it should be at least same as your anticipated crown length. If you cannot extend up to the 2/3 of the root, then it should be at least your same as your anticipated crown. Dinah, put that to the list. I have to share the reference for the same from Schillingberg. It should be 2/3 of the root length or same as your anticipated crown. When both are given as a choice, the root length is a better reference. Size of pulp chamber within the tooth is influenced by. So as we discussed in the case 9 in Odell as well, that size of pulp chamber changes with your chemical irritants, with your insults, the bacterial insults, the caries, and also that has happened, those insults like caries or bacteria or the chemical irritation, all that led to the tertiary dentine formation. Other thing that can also lead to calcification within the pulp chamber and hence reduce the size of the chamber is the age. With age, secondary dentine continues to get deposited. So if this was your initial pulp chamber, more secondary dentine will continue to deposit and the size of the pulp chamber will reduce. Or it could not be secondary dentine and it's coming from your mechanical stimulus or caries stimulus, then that would be your tertiary or reparative dentine. So all these age, parafunctional habits, abrasion, erosion, caries, all those insults to the pulp will lead to the decrease in the size of pulp chamber. So all of the above. Class 5 lesions can originate because, now class 5 lesions, what are they? In your posteriors and anteriors, the class 5 lesions are the ones which are confined in your facial or lingual aspect, but on the cervical third. So the lingual pits, which are the extension of your occlusal grooves. So lingual pits is your class 1. Buccal fissures are also the extension of your occlusal grooves, hence your class 1. Poor oral hygiene leads to plaque accumulation, especially in the cervical third, and that's where you get caries, which would be classified as class 5 in the cervical third. So buccal fissures and lingual fissures are your class 1. Occlusal cavities are class 1. The proximal involvement is class 2. Class 3 and class 4 are in anterior. Where there's no incisal edge involvement, it's class 3. Where there is incisal edge involvement, it's class 4. Retention for occlusal amalgam cavity in premolars is best provided by. So when you have occlusal amalgam cavity preparation, be it your premolars or your molars, in whatever situation, whenever you're preparing your occlusal box or occlusal cavity, the retention part is achieved by undercuts. Because it's a direct restoration, it is not an indirect restoration. So if you look at the cross section of this cavity, you will have slightly undercut walls. And this slight undercut, it adds to the retention of this direct amalgam restoration. So these undercuts are given only in the buccal and the lingual walls, never on the mesial and distal undercuts, because mesial and distal walls are comprising your marginal ridges. If you undercut or undermine your marginal ridges, they are your primary supportive tooth structure. So preserving your marginal ridges is extremely important, and that's why the undercuts are not given on the mesial and the distal walls, but rather only at the occlusal, buccal and the lingual walls. So you do not undercut the walls with inverted cone bar. This may be right, but only when it is talking about buccal or lingual walls, because the walls are not specified here. So A statement is not completely correct, because they could also be mesial and distal, which are never undercut. So B is completely not true. C is absolutely true, because these are the only two specific walls which needs to be undercut slightly so that it gives you the retention, that is resistance to the vertical dislodgement of your restoration. And whereas when you're giving your direct restorations like your inlays, then you have to prepare the cavity as divergent walls. Slightly divergent, where it's wider at the top and narrow at the base. Whereas in undercut, it's wider at the base and narrow at the top. When you're directly putting the material, you can put at the undercut walls. But if you're putting the entire restoration as an indirect restoration, it's coming in as a block. An undercut wall cannot be inserted. You cannot insert a indirect restoration with undercut walls, because then this wider part in between will get stuck on the narrow part of the occlusion. So an undercut is only given in your direct restorations. When you're talking and dealing with your indirect restorations like inlays, then you have to make divergent walls so that it can easily insert where the narrow part is at the bottom and the wider part is at top. What is true in regards to lateral mandibular incisor? It has 40% of them have two canals, where only 1% ends into foramina. This is a direct reference from Oxford. Dinah, would you please put that to the list so I can share the reference? Lateral mandibular incisor wall, the canal reference from Oxford. What is important requisite for fillers in dental composite restorative resins in load-bearing areas? Now, in load-bearing areas, you require higher compressive strength from your composites. Load-bearing areas require higher compressive strength, higher mechanical properties, and fillers impart mechanical properties to your composites. So when you are dealing with load-bearing areas, you're talking about class 1, class 2 in posteriors, and thus your fillers need to be more in concentration. More than their size, you require more of the concentration. So high in content. Coefficient of thermal expansion is your property of expansion or shrinkage, which changes in temperature. That is a feature of your resin and not your filler. So high coefficient of thermal expansion would be seen in the property of resin, not a filler, and it would be seen in more in your microfilled resins, where the resins are more. So in your load-bearing areas, you require less resin and more filler. So the overall coefficient of thermal expansion of that composite would be lower because resin content would be lower. Sensitivity to hot and cold foods soon after cavity preparation, and then you place GIC and composite in an upper incisor tool. What is the reason of sensitivity? Immediately after cavity preparation. So there could be various causes of sensitivity immediately after restorations. Then it says immediately after preparation. If the sensitivity started immediately after preparation, that means it was not because of the chemicals from the restoration, because it started before you put the restoration there, after immediately cavity prep. And GIC does not release heat to lead to that sensitivity. It is extremely biocompatible in pH and in temperatures, so it does not lead to sensitivity or put the thermal effect or thermal insult on the pulp. But the mechanical trauma to the rotary instruments can initially give you the mechanical insult to the pulp, and it would be a minor sensitivity, it would be a mild inflammation, mild response of the pulp. It's not even an inflammation. It's not even would be categorized as pulpitis because it would be immediately subsiding. So it would be an initial response of the pulp to that mechanical trauma or the mechanical insult during cavity preparation to all your rotary instruments. So that's the most likely cause. But if you got this sensitivity after the placement of restoration, not after cavity prep, but after the placement of restoration, you got this sensitivity, then the most likely chance is if it only gets subsided within days, if it subsides within days or weeks, then it was mostly because of the mechanical trauma. But if it gets subsided and if it doesn't get subsided and stays prolonged and is worsening, then the most likely cause is micro leakage. So that's why any sensitivity after restoration, the first advice to the patient should be to wait for a few weeks, because most likely then it is because of the mechanical insult or some chemical irritation from the restorative material. But if it is not getting relieved, it is not reversible, and it's worsening beyond few days and weeks, then it is leading to irreversible damage, and that means there is continuous insult, and the continuous insult is coming only from your micro leakage, because mechanical trauma would have subsided, pulp would recover from that, irritation from the restoration, pulp would recover from that, but it's the continuous leakage and continuous irritation from the bacterial fluids or the bacterial contaminants in oral fluids. So continuous irritation is the most commonly source of micro leakage. After completing your pulp extirpation, debridement, and placing a dressing after apical periodontitis develops, and that would be mostly because. So what you did was, you completed your pulp extirpation, you debrided, you placed a dressing also. So then you send the patient home. That's an inter-appointment flare-up that you're dealing with. Inter-appointment flare-up, and that flare-up is that you only have pain on biting. There is no continuous pain, there's pain on biting, or there is some periapical inflammation. That means there is an inflammatory sign in the periapical area. So after this first appointment of debridement and doing a dressing, if this inflammation set in the periapical area, what could have been the cause? Either you did an over-instrumentation, and that impinged and damaged or kind of mechanically irritated the periapical tissues, or whatever chemicals you used as dressing percolated and led to irritation in the periapical tissues, that's another cause, or any entrapped bacteria into the canal which then progressed into the periapical area and led to inflammation. So any or a combination of the above can practically lead to apical periodontitis after the appointment, after the first debridement appointment, and that would be called as an inter-appointment flare-up. In primary teeth, failure of calcium hydroxide pulpotomy is most likely to give you what? So now I have to discuss that concept with you, which I said I will when we come to that question. So let's talk about pulpotomies, DPC, IPC in primary. Today, with this question, we're talking only about primary, so that we do not confuse with the concepts of primary and permanent. Let's talk solely about primary for the moment. If this is your primary molar, pulpotomy is a process by which you will be only removing the coronal part of the pulp and preserving the radicular pulp. That's your pulpotomy. Removing the coronal part of the pulp, preserving the radicular pulp. So simple logic applied is, when would you do pulpotomy? When your coronal part of the pulp is inflamed and the radicular part of the pulp is healthy, not inflamed, right? That's only when you do pulpotomy. So when you do pulpotomy, you have to put a barrier, like a hard barrier formative material, on the opening of the pulp orifices, so that the hard barrier prevents the percolation of material, percolation of fluids and chemicals from your restoration material. So the two materials which are available to form those calcific barriers on the orifice is your calcium hydroxide and MTA. MTA has no contraindication in primary teeth or your permanent teeth. But in calcium hydroxide, with calcium hydroxide, it is contraindicated in primary teeth. MTA, never contraindicated in primary or permanent. Can be used in both. Okay, can be used in both. We are only concerned with our calcium hydroxide here. So calcium hydroxide is contraindicated with primary teeth wherever you see that there is inflammation. Wherever you find that pulp was inflamed or possibly be inflamed, calcium hydroxide, when you put it on the pulp, will lead to internal resorption. So answer is simple. When you put calcium hydroxide as pulpotomy calcific barrier, what is the most likely response? The failure, it would be because of internal resorption. So that's a fact. When you put calcium hydroxide on primary pulp, where there is a possible indication of inflammation, then the pulp shows an unexplained reaction of internal resorption. It is unexplained because the mechanism is not known. But it is a finding, and that's why you have to learn this. That it is a contraindication with calcium hydroxide pulpotomy. And pulpotomy is only done when the coronal part was inflamed. That means the inflammatory component is there, so you can't use it. Let's find one situation of calcium hydroxide where you can use it in primary teeth. So if it was a primary tooth, so when you're doing a direct pulp capping, direct pulp cap means that you're putting the calcific barrier instead of this orifice, you're putting it here on the exposed pulp. So you're preserving the coronal pulp and you're also preserving the radicular pulp. So direct pulp capping is putting the calcium hydroxide or MTA directly over the pulp tissue, on the coronal pulp tissue, on the pulp horn, where it got exposed. So the only situation where you can use it is where there was no sign of inflammation to begin with. And when can that happen? Can happen, suppose there was this caries here, which was within the dentine, not at all close to the pulp. Pulp was healthy, there was no sign of pulpitis. And the clinician was preparing the cavity for this tooth. And while preparing that restoration, while preparing that cavity, iatrogenically he exposed this pulp horn. So that means the caries was not in touch with this pulp form. There was no component of inflammation. There was no bacterial irritant. There was no inflammatory mediator. There was no already existing inflammatory sign. Iatrogenic pinpoint exposure during cavity preparation, it would not be called a carious exposure, mind you. That's not a carious exposure. Caries did not expose that. Caries was far from it. But the clinician, iatrogenically, while preparing the cavity, exposed it. So was there any inflammatory mediator there? No. Was there any inflammatory sign there? No. So would your calcium hydroxide show you internal resorption there? No. Because calcium hydroxide only shows internal resorption when some inflammatory mediator was there or some inflammation component was there. So if it was a natural carious exposure, would you do calcium hydroxide DPC or pulpotomy? No. Because there is carious in touch with pulp. There is an inflammatory mediator there. Then you can't use calcium hydroxide. Then you have to go with MTA or you have to use your ferric sulfate. And so calcium hydroxide in primary only done for iatrogenic and also pinpoint exposure. If it was a large exposure iatrogenically, then perform pulpotomy. Iatrogenic pinpoint, direct pulp capping with calcium hydroxide. If it was a large exposure, go with pulpotomy. Can't do DPC. If it was a carious pinpoint exposure, then you can do DPC, but with MTA, not with calcium hydroxide. And which is your carious exposure, which is large, pulpotomy. So iatrogenic pinpoint DPC, iatrogenic large pulpotomy, and pulpotomy is always with MTA. Carious pinpoint DPC, but never with calcium hydroxide because it's carious. Inflammatory mediator is there. If you put calcium hydroxide near inflammatory causing agent, you will have internal resorption. So go with MTA. Carious large exposure, pulpotomy with again MTA. Right? So answer you got, the failure would be with internal resorption, and you understood the concept of DPC and pulpotomies, iatrogenic pinpoint, carious large exposures, and whether you go with pulpotomies or will you go with DPC. We'll still deal with it much more in detail. I will reinforce them again, but I cannot be talking about one concept longer than that. So let's move on to the next one. But you revise it with the recordings as well. And also I will be talking about the concept again. In class 2 prep, it is difficult to place the gingival sleeve in primary teeth. This question is pertaining to primary teeth. So when you're preparing a class 2 cavity in a primary molar, there is a natural cervical constriction in primary molars. So because of that natural constriction in primary molars, giving a gingival seat is extremely difficult because it tends to get very narrow. Because of this constriction, the gingival seat gets very narrow. So it's very difficult to get a uniformly smooth gingival seat preparation in primary teeth. It's not a problem in permanent because you have a wider molars, big coronal structure, and also there's no cervical constriction, which is seen in your primary teeth. So enamel rods are directed occlusally, that's correct, but that doesn't give you any problem basically. That only does one thing, because enamel rods are directed occlusally in your primary molar. So when you prepare the gingival seat, you do not actually have unsupported enamel. So you do not need to give the bevel here, which you need to give in your permanent. Because of the direction of enamel rods occlusion, they remain supported. You don't find unsupported enamel on the gingival seat. So do you require bevel on the gingival seat in primary? No. Do you require that bevel on the gingival seat in permanent teeth? Yes. Why in permanent? Because enamel rods, they direct apically rather than occlusally, which they do so in primary. So this direction, occlusion, only prevents the bevel on the gingival seat. It doesn't give you any problem per se. The problem in preparing your gingival seat comes because of the marked cervical constriction, which gives you very less tooth structure to work with. So your burr actually might be larger than the amount of tooth structure that's available to prepare. Moist heat sterilization or dry heat sterilization or chemical heat sterilization for that matter, all is achieved by denaturation of protein. Initial priority in treatment of horizontal fracture. When you have horizontal fracture of roots, we're talking about root fractures. Horizontal root fracture, we can have it in apical third, we can have it in middle third, we can have it in cervical third. And the trauma article that I've shared with you beautifully describes the management of all these fractures. And when coming to the treatment part, I'll explain what is the management of all these fracture lines. So just for today, you can understand that apical third fracture has the best prognosis. The cervical third fracture has the least favorable prognosis. Middle third has the okayish, you can always imagine that. The apical third, the coronal fragment, most likely retains its vitality. Disruption is not much, the vascularity is maintained, the blood flow is not disrupted. In the cervical third, usually the chances of losing the vascularity is highest, and you have to sometimes extract the coronal fragment depending upon this level of your cervical fracture. So even if you get the signs of your coronal fragment going non-vital in your apical third fracture, so by any chance if you find that it was an apical fragment, this is a coronal fragment, this was below the fracture line would be your apical fragment. So apical fragment would always maintain its blood supply, very less chances that will go non-vital. But if this got displaced, the chances are that the coronal fragment might lose its vitality. And when it does so, you'll find it as a radiolucency surrounding the fracture line, and you will find that the fracture fragments are separated by more than 1 mm. What will you do? You will only perform RCT till the fracture line. You would not perform it below the fracture line because this fragment retains its vitality. So you debride the pulp only till fracture line, give a calcific barrier till here, and then fill with calcium hydroxide dressing, and then after few months, you seal it with your permanent restoration, permanent obturation, only till your fracture line. After that, in future, if you think that, or if you find that apical fragment has also lost its vitality, then in that case, you can perform a periapical surgery and remove that apical fragment if required. So whenever all this horizontal root fractures present to you, the first priority is to stabilize your fracture fragments, because if they remain mobilized, then the chances of disruption of vitality is higher. If you maintain the immobilization, fragments are kept together, the chances of retaining the vitality of the coronal fragment increases. After you immobilize, then you decide. If you don't think that the coronal fragment has lost its vitality, do not require to do any treatment at that point. Do not do RCT. RCT of the coronal fragment only comes in when you see the signs of necrosis or loss of vitality in the coronal fragment. Healthy dental pulp responds to injury by, so like this, the one we saw in case 9. It was a healthy pulp, there was injury to it by chemical insult, it could have been a mechanical injury, whatever it is, the pulp's response to that injury is laying down of more reparative dentine and the pulpal surface and trying to build more calcific barrier and shrink in size. So the pulp chamber reduces in size, reparative dentine is formed at the dentinal pulp interface in response to that irritation. The most common cause of fracture at the isthmus of class 2 dental amalgam restoration. If you remember, I showed you from Mountain Hume also in the other class that the most likely cause of the fracture site of amalgam is at the isthmus. The cause is there is insufficient bulk, and the bulk is composed of two things, width and depth. And when comparing the both, the depth is more important. If your depth was inadequate, the chances of fracture would be higher. So more than width, it's the depth that is insufficient that leads to that increased fracturing at the isthmus. The sinus tract is indication of, so sinus tract, if you remember from the Odell case 1, when he was dealing with that mandibular grossly decayed molar, it had a chronic periapical abscess and there was a sinus opening on the soft tissues, which is pathognomonic sign of a chronic periapical abscess. It was an abscess, pus developed in that abscess, and then it went out through the soft tissues and the bone, and that opens itself as a sinus tract near the apex of the infected tooth. So it's a pathognomonic sign of chronic periapical abscess. Class 3 cavity is, now class 3, as I explained just before, is your cavity in the proximal surface, slightly gingival to contact area, not involving your incisal edge. Class 4 would be your class 2 cavity extending up to your incisal edge. The principal cause of failure of amalgam restoration. Now let's look at the reference here. Mountain Hume, page number 209. So the operator-related factors of cavity preparation and manipulation of amalgam are the major causes leading to early failure. So most important factor for the failure of your amalgam restoration is cavity preparation, and then comes your manipulation of the amalgam, the trituration or the mixing of the amalgam. So first is the cavity preparation, then is your manipulation of amalgam, which are the two leading causes of restoration failure. So the principal cause of failure would be either improperly prepared amalgam or improper cavity prep, not your peri-involvement of particles of amalgam. So amongst these two, on the first priority is written your improper cavity preparation from your Mountain Hume. I think I could not share my Mountain Hume screen. Let me just reshare it for you. Here. The operator-related factors of cavity preparation and manipulation of amalgam are the major causes leading to the early failure. Yeah, here it is. I hope everybody can see it now. All right. Reduced occlusal area means, reduced occlusal area, although this question language is not so clear, but reduced occlusal area of the amalgam would mean, that means if the amalgam was not spread over the larger occlusal area, it would lead to the less fracture potential for amalgam. A wider amalgam is more prone to fracture than a narrower amalgam, because a narrower amalgam takes up the compressive strength, compressive loads better than a wider amalgam restoration. So reduced occlusal area of the amalgam leads to the less fracture potential for amalgam. It is more conservative and takes up the occlusal loads because it would not be following, it would be away from the occlusal stops, it would have less occlusal forces on its surface. Larger surface area on occlusion would mean larger occlusal forces, larger load bearing. So that would lead to more chances of fracture. Narrower would mean less forces per unit area and thus less chances of fractures. Less mercury remaining in the ultimate condensed amalgam. When you have less mercury remaining in the properly mixed and condensed amalgam, so mercury weakens your restoration. Mercury leads to the voids, mercury leads to the weaknesses, and it's a weaker alloy or weaker matrix or component of your ultimate amalgam alloy. So less mercury remains. And how can you reach the less mercury? First is following the 1:1 mixing. Do not have excess mercury mixed with your silver alloy. And the next is proper condensation, by which you are making sure that the mercury rich layer reaches the top, and then you overpack your amalgam, so that that mercury rich layer is removed off while carving. So that's how you ensure that the ultimate amalgam restoration is as less in mercury as possible. First the mixing ratio, then proper condensation so that the mercury rich layer comes at the top, and then your overpacking of amalgam so that the topmost layer of the mercury rich amalgam is taken off by your carving, and the final condensation. So ultimately, the stronger the restoration, which contains fewer matrix alloys and fewer voids. So less mercury would ultimately lead you to a stronger restoration with superior compressive strength, less voids, less weak matrix alloys, and ultimately superior corrosion resistance, because excessive mercury leads to more corrosion, less physical properties, inferior physical strength, inferior compressive strength, inferior tensile strength. So less mercury is superiorly performing physical properties and more corrosion resistance. So less mercury, stronger the restoration, less matrix alloys, less voids, and thus is your answer. High copper amalgams are superior. Now in the last class, I gave you the reaction of copper with amalgams. So when you add copper with your amalgams, you eliminate the gamma 2, which is your tin mercury phase. When you add the copper, more than 12%, which is your high copper, you eliminate the gamma 2 phase by forming the eta phase, which is your copper tin phase. So it eliminates the gamma 2, which is the weakest phase. So the high copper amalgams would be superior, would be more corrosion resistant, would be more physically superior only when your copper would be available for that secondary reaction where it eliminates the gamma 2 and gives you eta. If the copper isn't available for a secondary reaction, well, we don't have a gamma 2 eliminated, we don't have an eta phase, so we don't have superior properties. So copper needs to be available for the secondary reaction. Concerning the condensation of restorative gold. So it is talking about DFG here, direct filling gold. When you were using gold as a direct restoration, it is no more used, but this question is an old concept about your direct filling gold. When you were concerned with condensation of restorative gold, so you prepared the cavity and then you were filling it with your gold pellets or gold sheets or gold foils, various forms it was available, in form of pellets, in form of sheets, matte, or your foils. So then you used to fill it like your amalgam and then condense it properly, one sheet over the other. So concerning the condensation process in your DFG, direct filling gold restoration, it does not vary widely and it has an absolute effect on the final restoration. If you do not condense it well, there would be voids between the gold where it would not form cohesive bonds. So if they do not form cohesive bonds, they are not properly condensed, there would be voids giving you inferior restoration. So it has the ultimate outcome effect on the outcome of the final restoration. So A is absolutely wrong. The degassing procedure is extremely important because it removes the oxides from the gold surface. When you remove it, Only then the gold layer can form the cohesive bonds with the next gold layer. If you have oxides, the next gold layer would not form the cohesive bond between the gold, because you need to form the gold and gold cohesive bonds. If there are oxides formed, then the gold and gold would not be available for formation of cohesive bonds, the metallic bond. So to form that, the oxide layer is eliminated so that this becomes sticky to each other. So degassing is done by eliminating this oxide layer. So degassing allows for the cohesive bond formation between two gold layers. It is the Achilles heel. Achilles heel means the most important step. So it is the Achilles heel of direct gold restoration, most crucial step. C is correct. Clinical techniques are more important than the physical properties of restorative gold. Both are equally important. No matter how impeccable your clinical techniques are, if the physical properties were not taken care of, if there was oxides, if the metallic cohesive bonds did not form, your techniques would not make any difference. The physical properties, the degassing, is also extremely important. So C is the correct statement. Rest all are false. In regards to your enamel surface, now that's your direct Gardner question here. It is not perfect for bonding to begin with. You made it perfect for bonding by etching it, by creating gaps and microporosities in it. So it does not conform to the bonding requirements on its own. It needs to be modified to the bonding requirements by performing your etching. It is the most inorganic rough part. Well, that's incorrect here. It is the most inorganic, but it is smooth. It is free from contamination and roughness. Well, it is smooth, but it is not free from contamination. It has all your saliva, pellicle, plaque on it, which needs to be removed by etching. So B is correct statement. Rest all are false. Acid etching of enamel and eroded dentine. So when you etch your enamel or dentine for the restorations, it is a non-traumatic, conservative clinical approach to the bonding of restorative material. Etching is non-traumatic. It only creates microporosities and demineralizes temporarily. It is reversible. If your excessive tooth structure gets etched where you did not need to put your bonding agent or your restorative material, it is not going to traumatize that tooth structure. That enamel will come to its original form within days. So it is non-traumatic and conservative approach. It helps you conserve the tooth structure because you're not relying on the mechanical features of cavity preparation for retention. You're not relying on undercutting of walls. You're only relying on the bonding, and thus you can actually preserve even unsupported enamel there, which you just saw in the case 9 there. So it's a conservative approach. It is not traumatic, so B is wrong. It is safe. So it is not safe and simple. Well, it is very safe. It carries no risk. And if bonding fails to produce a highly significant retention and good marginal integrity, well, the bonding achieves good retention. It gives you marginal integrity. That's what bonding is for. So B, C, D are not true. A is your true statement, and hence your answer. The effectiveness of the acid etch is dependent on which of the following factors. So usually it would depend on the concentration of etchant. You do not require to clean the surface of the tooth. Etchant is sufficient to clean. You do not require to perform scaling. So you do not require to just perform a scaling and prophylaxis appointment before that. The etchant would be sufficient to clean the surface and remove the plaque. It does require slightly on the effectiveness on the etchant, but more so, it depends upon the chemical and physical nature of the tooth. How inorganic component, how much inorganic component is there, how mineralized the enamel is. Because hyper-mineralized enamel would be difficult to etch, would require longer times. So the dentine being less in mineral content requires lesser etching time. Enamel being more in mineral content requires more etching time. So the chemical and the physical nature of the tooth is more determining factor of making the etching as an effective process than the effectiveness of the etchant on its own. Creep in the amalgam is greatest in. So now creep is a feature. It is a time-related property of amalgam. Time-related change in the dimensions of the amalgam. So dimension of the amalgam changes. That means it slightly widens or it narrows. With creep, either it moves above the tooth surface margin, over it, or it detaches and moves away from the tooth margin. It can happen and it can do both. It either expands and moves onto the margin tooth structure, that is also called creep. It also leaves and moves away from the tooth structure, that is called ditching. Ditching is also an outcome or the response of creep. Ditching is also because of creep. So if it moves above the tooth surface margin, then also it is getting more prone to fracture and then leading to gaps and microleakage. If it leads to ditching, then also it's leaving gap between tooth surface and the restoration, again leading to microleakage. So creep basically leads to gaps between the tooth and the restoration, thus giving you microleakage, making it prone for your secondary caries. Creep happens because of the corrosive products. Why does the shape of the amalgam changes? It changes because more corrosive products get formed, and because of that corrosion, the shape and size of the amalgam changes. So if creep is the response of corrosion, what leads to corrosion? More amalgam, more gamma 2 phase, that's your tin mercury phase. Those are the weaker components leading to corrosion. So if your gamma 2 is linked with corrosion, what has more gamma 2 phase? Low copper or high copper? So it's your low copper late cut. If you have the option of low copper late cut and low copper spherical, how will you pick between? Both have low copper. Now which has less mercury amongst these would be more prone to or more resistant to creep. So which would have more mercury would be more corrosive, more prone for creep. So amongst the late cut and spherical, which requires more mercury to wet all the surface? Imagine you have this late cut, irregularly shaped, and you have spherical. Same amount of particles, just different shape. Where would you require more mercury to coat all the particles? Where you have more irregular surface, you require more mercury to coat it. Where you have uniform spherical surface, you require less mercury to coat that uniform surface. So spherical requires less mercury, late cut requires more mercury. Which one has more mercury? Late cut. Which has more mercury will have more corrosion, proneness to corrosion, and thus more chances of creep. So even if you were given the B option, low copper spherical, you know your answer is low copper late cut because that wants more mercury to coat it. More mercury means more corrosion means more creep. Hope that makes sense. Now coming to surface of enamel rods, prisms and permanent teeth, it is usually believed that the enamel rods are perpendicular to the outer surface of the tooth. Now recent studies have been conducted and it has been found that instead of only in cervical and the cuspal areas, other than that, most of your enamel rods are parallel to the long axis of tooth. So in exam, here you don't have an option, but I'm writing it for you as a concept you must know. If you get that option in exam, they are parallel to long axis of tooth. It is only earlier believed that they are perpendicular to throughout the outer surface of your tooth. That's not true. Only in cervical and the cuspal edges, cuspal areas, it's true. Rest of your enamel surface, they are parallel to the long axis of tooth. Dinah, please put to the list so I can check the reference. all of the following are properties of fluoride except it does cross placental barrier, reaches the fetus from the mother, it gets deposited rapidly in bone and teeth, all the mineralized structures in the body, it gets excreted by kidneys, and in higher concentrations is bacteriostatic as well, mentioned in your TG as well. But it gives you intrinsic stains in the teeth by affecting the mineralization of your enamel. Affecting the mineralization of enamel, it gives you intrinsic stains or mottling of the teeth, doesn't give you extrinsic tooth stains. So E is incorrect, rest all are true. When a probe penetrates between tooth and amalgam, it is not always an indication of caries. If there is a gap between the tooth and the amalgam, that is called ditching. It is leading to mitral leakage, and it can always lead to caries, of course, but it would not still always mean that the gap is present and it is caries. For caries to be present, you have to have tooth structure involved. There has to be carious involvement of the adjacent healthy tooth structure, radiographically, which is appreciated as a radial sensory. So not always all the gaps would be carious, but they can lead to caries, thus should be repaired. So amalgam ditchings, instead of replacing, should be repaired. What is the objective of pulp capping? When you cap the pulp, you were capping the pulp points. So that means you were preserving the entire pulp. So B, what is the objective of pulpotomy? When you were doing pulpotomy, you were putting the barrier at the your canal orifice. So you were removing the corneal pulp and only preserving the radicular pulp. That's why answer here is C. What contraindicates your pulp capping? Now let's talk about pulp capping contraindications. Slowly and steadily, we'll build the concepts regarding the pulp cap, pulpotomy, indications, contraindications. That's all you need to know about them. How is mostly simple. In permanent, MTA or calcium hydroxide. In primary, 99% MTA, only with your pinpoint iatrogenic exposure, you do with your calcium hydroxide, right? So agents you know, indications and contraindications is what you really need to understand and grasp. So let's talk about them. We're talking about pulp capping. Pulp capping means direct pulp capping here on the pulp horn, minor exposure, right? What contraindicates? That means where would you not perform it? Accidental exposure on a vital young molar. It's an accidental exposure. It's a young molar. So if it's a young molar, it's immature. If it's an immature molar, you want to preserve the pulp at all the cost to continue with the root formation. That's called your apexogenesis. And because it's an accidental exposure, that means the pulp was not inflamed. So you can actually cap this. Because the pulp was not inflamed, it would respond really well to the healing. This can be sealed off. Accidental exposure, no inflammation, no carious exposure, young molar, immature, you desire apexogenesis, go ahead, pulp cap it. Then there was inflammation of the radicular pulp already present. Hello. When the radicular pulp is inflamed, we can't even think about pulpotomy. Forget about direct pulp capping. We have to get rid of the coronal and radicular pulp both here, and we have to do the RCT. Pulpotomy also requires the radicular pulp to be free of inflammation. So if radicular pulp is inflamed, you cannot preserve this. You cannot preserve the entire pulp. You have to perform RCT. So B is a contraindication. When the roots are curved and tortuous, well, the direct pulp capping or pulpotomy is not related to the anatomy of the roots. It is only related to the physiological state of the pulp. The pulp has to be inflammation-free. For DPC, it has to be entirely inflammation-free. For pulpotomy, it should be inflammation-free in the radicular pulp, and the coronal part of the pulp should also be only reversibly inflamed. So anatomy of the roots, not linked. When your anterior teeth is vital, immature, and wide open apex, you desire apexogenesis. You desire root to be formed. And it is vital. When they say vital, we are safe to cap it and we are safe to preserve it. So A, C, and D would indicate pulp capping. B would contraindicate it. B requires RCT. Even pulpotomy would be contraindicated in B. Right? 2 successive negative cultures are not absolutely necessary. Not all endodontic treatments require culture taking. Only the non-respondent cases require your culture taking so that you can use a directive antibiotic therapy. But they are not always necessary for a successful endodontic treatment. You may have a positive culture, but still can cut off the substrate supply and can expect a successful endo treatment. So they're not always necessary. They're not absolutely necessary. You do not require them. But even if you get them, you can still expect successful endodontic treatment. So B is true. They're not questioned today as a dogmatic requirement in endodontics. Well, in certain cases, they may be a requirement, like in non-respondent cases. So they're still may be required today. And unquestioningly, it is adhered with for successful endo? No. It only means what A means. Unquestioningly, you should obtain them or absolutely necessary? No. You can still have some positive culture and still expect successful endo treatment. But sometimes you may require culture for antibiotic sensitivity because in non-respondent cases to RCT, conventional RCT. What indicates a need for periapical surgery? On this note, Diana, remind me, I have to share the small, beautiful, well-informed article about the periapical surgery. You read that article for surgery. For periapical surgery, you don't need to read a thing more than that. Beautiful, explanatory, simplified article. You would not find that simplified information on periapical surgery elsewhere. So what indicates? When do you need to do periapical surgery? When you're performing an endodontic treatment on an existing root canal filling, and you know that if you do the retreatment, it can lead to the fracture of the root, would you attempt that? No. If I know if it's a post-treated root, if I try to take out that post, if it's a good post, I would not try to take that out and risk the root for fracture and destroy more dentinal structure, but rather I would go for a periapical surgery. Only if my endodontic filling was correct. So it's an existing filling, but if performing the retreatment leads to the fracture of the root, I would rather go for surgery. So A is correct indication. When the treatment was faulty, if my treatment was faulty, RCT was faulty because of the wrong obturation, because of incomplete debridement, then even if I did endodontic surgery, that fault will still lie within the canal there and would still lead to failure because the coronal seal would be lacking, or the lateral seals would be lacking, or there was incomplete obturation. So I have to do the actual orthograde retreatment there. So B doesn't require surgery but requires actual orthograde. Orthograde means from the top. Retrograde means from the peripipe. So it requires orthograde retreatment. Where there's a risk of involving other anatomical structures, then why would you go peripipal if there's a risk of involving structures? Don't go then. So it would be a contraindication to surgery. If you had a bony defect, which was so extensive that edges of incisors will collapse, that means there is no remaining bone structure to the root, would you compromise with bone and peripipal root more by performing surgery? No. So B, C, and D would be contraindication. A would be the indication for surgery. In regards to your external root resorption, It doesn't continue after successful endo, and it stops after the endo treatment is achieved because the source of infection and inflammation is removed. And that's why in most cases of trauma, where you get external resorption, the likely outcome after the trauma or the necrosis, most likely after your RCT, the resorption stops. It continues only in mandibular incisors after successful endo treatment, where there's no affiliation of external resorption with mandibular incisors whatsoever. And also no affiliation with maxillary lateral incisors for that matter. It's true for B statement. B statement stands true. You achieve a good endodontic treatment. You remove the source of infection and inflammation, and most cases, external resorption arrests. If there's a concomitant periapical lesion as the cause of endodontic failure. Now for this, I would like to share the Voltin and read a bit about your concomitant lesions. So there are various kinds of concomitant lesions present. Let's look at them and briefly understand them. So there are combined diseases. That means the perio and the endo problem exist together. There are 4 kinds. One is, so basically you have primary endo disease that you know that there's only endodontic involved. So one is primary endo, other is primary perio, other is combined disease. Combined disease will have 3 kinds. Primary endo, which gives you secondary perio, then primary perio, which gives you secondary endo, and then true combined, that means both started as separate entities and are existing together on the same tube. No one is responsible because of the other. They were originally existing by their own etiologic factors. Okay? So these are 5 various classification of perio endo lesions. 1. Exclusively primary endo, no secondary involvement. So how would you find primary endodontic disease? So in your primary endo, you would find the pocket would be like a sinus tract, and the sinus tract would be of pulpal origin coming from the periapical area. That can also extend into the periodontal ligament, up through the canal, up through the lateral surface of the root. But when you probe this kind of pocket, it would be a deep, solitary, narrow pocket, and there would be no periodontal disease on that too. So you may have a periodontal pocket, which would be deep, narrow, only present on single root surface, and that is coming from an endodontic origin or from a vertical root fracture. And that's your primary endodontic disease. Radiographic findings would be, as it would progress and involve the bone, you will find that there would be a widening of medial space of the affected tooth. You would find a periapical radiolucency, which is extending from the apex to the cervical area along the lateral border of the root, like a J-shaped radiolucency. So that's your primary endo. If you look at this picture here, look at my hand pointer. Can you all look at my Voltin, I'm sure? Okay. So this is your periapical or your J-shaped radiolucency of a periapical abscess, which is linked with vertical root fracture, or your chronic periapical abscess, which has taken the root towards the lateral wall of the root. Vertical root fracture is also mostly linked with your post-treated endodontically treated teeth. So that's your primary endo, no perio at all. But gives you a pocket, so you may think it's perio, but it's not. It's purely endo. Prognosis, primary endo usually heals after RCT. So what's the treatment? Purely RCT. Do you require perio treatment? No. Because is there any perio disease? No. Going to primary perio disease. Primary perio is, it's caused by periodontal pathogens because of physiologic agents like plaque and calculus, and the pockets would be wider, not narrow, like you're in your primary endo. You'll also find angular bone loss, and you may also find your supra bony pockets, horizontal bone loss. Lesion may not be limited to just one tooth, involve adjacent teeth as well. In contrast to your primary endo lesion, there would be absence of buccal, lingual, and both plates. That means the bone loss would be on the buccal plate entirely, not like your narrow, bony, or your pocket. Pulp test would be positive. So even if we see it as a periodontal abscess on radiograph, the pulp test would be normal. And that's why it is an important test to distinguish between primary endodontic disease or primary endo abscess and primary periodontal disease like a primary perio abscess. So that answer question also gets sorted, and you have the reference here. The pulp test is the most important test to distinguish between perio abscess and periapical abscess. That's your answer there. So probing pattern, there you have narrow, solitary, deep pocket. Here you have a wider pocket, which is going towards the apex. Perfect. What kind of treatment do you require? For this, prognosis is good only if you have the progressive periodontal disease. So only treatment is periodontal treatment. There is no endo, no RCT required. So primary endo and primary perio solitarily, not a problem to identify, not a problem to know the treatment. Coming with combined diseases. Primary endo with secondary perio involvement. What are the clinical findings? What is it basically? It is basically that it started with a primary disease, right? If a suppurating or pus-releasing primary endo abscess remains untreated, then it can go up to the margin of the bone and reach the cervical marginal bone and lead to the marginal bone breakdown. And then you would get long-standing accumulation of plaque and calculus also. So bone destruction would take place, so periodontal destruction is taking place, but where is it coming from? Not originally from the plaque and calculus, but because of long-standing endodontic pus. Plaque would be found at the gingival margin of that sinus tract, which will further lead to marginal periodontitis, but that would only be secondary plaque and calculus, not originally starting because of that plaque and calculus. So when the plaque and calculus is present, treatment and prognosis of the tooth are different than for the teeth involved with only perio, with only primary endo. We know when there's no plaque and calculus and the pocket is only primary endo, it's only RCT. But when there's secondary perio, then what happens? Prognosis will depend upon the severity of marginal perio damage. Even with secondary perio, the prognosis is dictated by the amount of remaining periodontal support. So what will be your treatment? With endodontic treatment alone, only that part of the lesion, which is endodontic etiology, will heal to the level of the secondary periodontal lesion. So the first management is you do only endo, and sometimes it would completely heal. The secondary perio would completely heal because it was only there because of the primary endo and not because of its own patient's own plaque and calculus problems. Root fractures can also mimic the appearance of primary endo with secondary perio. That typically occurs on endodontically treated teeth with post and crowns. So root fractures are purely primary endo lesions. They are not secondary perio, but because of that radiolucency, it may look like it's periodontal as well, secondary perio as well, but it's not. So primary endo with secondary perio treatment is do only endo, and secondary perio may only heal on its own. Secondary perio may not require any treatment at all. Coming to primary perio with secondary endo, it started as your plaque and calculus induced primary periodontitis, and because of involvement of lateral canals or apical foramen, the pulp also gets infected. a strong correlation between the presence of microorganisms in root canals and their presence in periodontal pockets of advanced periodontitis has been seen. So started as your pathogens were all periodontitis, and lateral canal got involved and thus give you pulpal involvement too. So what would be the prognosis and treatment? So in single rooted teeth, the prognosis is usually poor with your primary perio and secondary endo. In molars, prognosis may be better because all roots may not have suffered from the same periodontal loss. In such cases, root resection would have been considered as an alternative treatment. Right, let's look at the treatment option here. Okay, just a second. All right, it's not mentioned here, but for your primary perio and secondary endo as well, the first treatment is endodontic treatment, and then you perform your periodontal treatment. And now the prognosis would depend again on the remaining tooth structure periodontally. So you can remember it like this: when you have combined lesions, treatment will start with endo, and then perio may or may not be required. But when asked about prognosis, then the perio status in any combined lesion, whether it's primary or secondary, the prognosis is dictated by perio status, and the treatment is started with endodontic management. In a true combined lesion, endo-perio disease occur concomitantly. Disease progressing coronally, so endo progresses coronally, and perio goes apically, and then they meet. So perio destruction was starting from cervical area going down, endo destruction starting from apex going up, and then they meet. So they were simultaneously happening. Perio was happening because of plaque and calculus, apical was happening because of non-vital part. Prognosis is usually guarded. Periapical healing may be anticipated after successful endodontic treatment. So in this also, the first treatment is your endodontic treatment, and then periodontal tissues may not respond well to the treatment, and again, the outcome will be dependent on the periodontal severity. How much severe is your periodontal destruction? So to remember that in an easy manner, start the treatment with endo. Prognosis will always be dictated by your periodontal status. Coming back to the question that we were discussing, when you have a concomitant, that means your true combined perio and periapical lesion as the cause of endodontic failure. So when you have a true perio lesion, if your endo was failing, or if this tooth was failing because of the true combined periapical lesion or true perio-endo lesion, the cause would be most likely what? The periodontal loss. Is that correct? Everyone follows? Yeses for this, please. So that I hope that this has some way percolated. It would be failing because of perio destruction, right? So if your endodontic failure is happening because of true combined periapical lesion, then the cause is the periodontal destruction. And can you not discover that before you even begin your RCT? The periodontal destruction would be evident to you, right? The bone loss, the pocket depths, the radiograph. So you may not even start or attempt RCT if you have no remaining periodontal structure to that tooth. Yes or no? Some more yeses for that? Just so I know that it is making sense. So can you not discover that chances of failure? Because you would know the remaining periodontal structure. Yes? Makes sense. So cannot be discovered? Not true. It may be discovered prior to endo treatment and commonly found in maxillary or mandibular. No. It is mostly linked with anterior or posterior. Usually it fails with anterior, single rooted. May have some successful outcomes in posterior where you have more periodontal remaining structure. So more roots, so one can be compromised, but some can be preserved. So B is your most accurate answer here. And on that note, we'll terminate today's class session. At what level of perio destruction, Anshu? You can decide that whether it would have poor prognosis. Well, that is a clinical decision. Depends upon the amount of mobility and the location of that tooth, the load that tooth is taking, how much you can expect the tooth to respond to the treatment. That's what I'm saying. It may be depicted before the treatment. It's not that you will always know and then just simply say no to RCT and extract it. But in some situation you would know, and in some situation you may attempt saving it, right? So it depends upon the tooth which you're talking about. If it's single rooted and there's mobility and a lot of attachment loss and bone loss has been taken place, then the chances of and prognosis and preservation would be poorer. In perio, if perio is severe, in combined lesion, what do you do first, Mommy? You do endo first because you want to first remove the infection from the endo aspect. And then you remove the plaque and calculus. Because when you treat, it's given in the Walton here also. Let's look at this again. When you treat the perio first, there's a chance that you are infusing more bacteria into the canal. In your true combined, let me just show you here. So here you find the answer to that here. Then primary endo disease should only be treated by endo. Excellent prognosis is expected. Primary endo with secondary perio should first be treated with endo. Treatment should be reevaluated in 2 to 3 months and then decided whether perio is required or not. Then coming to primary perio with secondary and true combined, the prognosis depends upon the severity of periodontal disease. They require both endo and perio treatments. Of course, true combined disease usually have a more guarded prognosis. In general, adequate endo treatment will result in healing. So when you do basically, when you do endo first, you achieve healing. And then you decide whether you need more periotherapy or not. But when you do perio first, you're actually adding on to the bacterial load in the canals. Let me show you here. Where is it? Give me a while, I'll just find it. Yes, of course, I will share this highlighted book so you can read it. Okay, page number is mentioned on the file. Let me show you, please. So treatment complications of periodontal disease. Can you see my blue highlights, everyone, on the left side of the page? Treatment complication of periodontal disease can lead to secondary endo involvement. So when you do perio first, you are in fact infecting the canals more. Because of the scaling and curettage, you're actually putting more bacteria into the canals. That's why endo first, that decreases the bacterial load and leads to periodontal healing as well. Okay, so primary endo, only RCT. Primary perio, only periodontal treatment. Coming to your combined lesions. Primary perio, primary endo, secondary perio, first RCT. Then may or may not you require your perio treatment because it usually responds only with RCT. Primary perio with secondary endo, again do first RCT, then you may require to do perio treatment. True combined also require RCT and perio treatment, but first RCT and then endo. So if you go at the end of this chapter here, It's given here. Primary endo, what treatment? Primary perio, what treatment? Primary endo with secondary, what treatment? Everywhere, first endo, then perio may or may not be. Yeah. So it's making sense. Yeah, it's confusing, but if you reread it, keep revising it with your study partner, it will start making sense. But at least you got the gist of it, right? Intra appointment, I'm going to discuss it in the Friday class. Let me discuss the flare-ups on the appointment on the Friday class, Akshita. Yeah. Shall we wait till Friday for that? All right. Okay. Some more chats. Perfect. So I hope you enjoyed from today's class, learned a lot. Yeah, so a lot from your Odell case also, so many takeaway points, so many beautiful concepts to learn and understand, and also with your 1000 MCQs, as I told you, with your MCQs, you're going to build up so much of information. It's going to be hell of a ride. So I hope you keep enjoying. Please keep sending me feedback, especially the new guys, so that I know that the process is flowing with you. The process is making sense with everyone. So I need to hear constant feedbacks because that keeps me going. So the only thing that I need from you is your feedbacks. Whether good or bad, I don't care about them. I totally embrace both of them. Okay? All right, so all the questions, please forward me on my WhatsApp chat privately to me, 4 to 5 doubts per day, and I will be answering by tomorrow. And I'll see you guys on Friday now.